filed for everyone today. And then I'll share my screen and kind of walk through everything.
As you're sharing, I can also introduce you real quick if you want.
Sure.
So Samantha is a graduate student at the University of Michigan studying information and data science, and her primary interests involve the interaction of data and society, especially as it relates to events and sustainability. And in her free time, Samantha enjoys spending time outdoors with her two dogs, Juno and Hercules.
Yes. Who you will not be able to hear tonight, which you'll thank me for. Yeah, so I just started at the University of Michigan this semester. This is my first term, which we are finishing up in the next week or so. And I study data analysis and information science. Earlier in the year, I participated in a datathon that was hosted by Stanford University, and my team placed second with our analysis of the COVID-19 data for our topic, which I will go into a little bit later. To begin with, I will touch a little bit on regression analysis in general. Basically, it's a pretty basic way of modeling and making predictions of relationships between two variables. And I have a nice diagram here that just shows correlation coefficients, which provide a numerical value to describe the strength of a relationship between two different variables. This is just like a I don't remember what the term is off the top of my head, but just two variables. There's also multivariate regression, which is has a little bit more to it. But our project or our project submission just focused on like linear relationships between data. So I did prepare an example based on some data that I pulled from Kaggle. The link is here, but I also have a Python file as well as a like a Google Colab notebook, which I'll switch over to real quick. This guy here. So as far as getting your data in Python goes, there's a couple of packages that need to be imported. These are pretty standard for data analysis, pandas especially. Seaborn is a package that does a lot of like data visualizations. NumPy is, your does a lot of numeric functions. And then there's also matplotlib. I tend to prefer Seaborn over matplotlib just because it's, in my opinion, it's a little bit more straightforward to use. But I've imported both because I have a way to show both of these plots. Reading your file into the program with Pandas is pretty easy. It reads it into a data frame, which is this sort of nice layout here. I forgot to ask, can everyone see my screen okay? Okay.
Yep, we can see great. And also, great. If anyone has questions along the way, feel free to put them in chat, and Samantha will take pauses and we can get your questions answered.
Yeah, absolutely. If anyone's familiar with your typical reading a file into program with, like your with open statement, Pandas makes it really easy. You just use this read CSV. And then I've included a URL here that has my raw CSV file from my GitHub. And then that reads it in. And this line of code actually just renames a column. I've taken the white space out of here and just replaced it with an underscore to make it a little bit easier to use later on. And then you can see there's a couple of columns here. There's one thing that I didn't show is how to, view all of your columns and, more than just a couple of the first few and the last few observations. So if you're interested in that, let me know and I can show you how to do that. And I wanted to filter this a little bit based on nonfiction genres instead of fiction and nonfiction bestsellers. So here, this is a filter function. So I just filtered on genre and then filtered for nonfiction. And that gives me all of the observations that are nonfiction. From there, data exploration is pretty important. When you're starting your analysis, I've just done a pretty basic heat map to look at correlation coefficients to see which variables might have some kind of relationship. And the lighter the square, the higher the relationship that exists between the two variables. So the two I was interested in were year and reviews. This has a higher, looks like a little bit of a higher correlation coefficient. And then I was also looking at year and user rating. So down below, I've got two scatter plots, one with the year and number of reviews, and then one with the year and user rating. The first line, this first scatter plot is made using Seaborn. So it's just SNS, which is how I imported the package with the scatter plot, and then you identify which data you're using, your X and your Y axes. With matplotlib, it's a little bit backwards. You kind of, use the method on your data, and then you identify your two X and Y variables, and then what kind of plot you want, which is in this case scatter. So from here, we can see a slight trend that the data shows. So I've taken this particular data set and done a little bit of basic regression here. I basically changed both of these into NumPy arrays so that way I can fit a linear model to them. This is another package. I'm not particularly familiar with this one. I'll go into a different package a little bit later. But I wanted to touch on this because this is the package that my team used to perform their regression analysis with our COVID data. So it's sklearn, and we imported linear model. You define a model, and then you fit it to your two variables that you defined as the NumPy arrays. And then here I've asked for the correlation coefficient and the model's intercept, which is where that line starts, basically where that line hits the y-axis. So let's see here. This chunk here is just applying this line to the scatter plot, and you can see there's a little bit of a positive relationship here. And I would like to identify how well this line fits this data. And in order to do that, I've used a couple of stats models packages. So these are some packages that basically you can use some R-styled lines to get some nice outputs. So I really like them because I went from R to Python. So here this OLS stands for oh my gosh, ordinary least squares, which is your basic regression. So I've defined a second model here, and this is number of reviews by the year. So in this case, year is our X variable and reviews is our Y variable, which is a little bit different than your typical setup. And that's just the way that R typically defines models. And it's read in as a literal string. So quotations are important to use here. And then we define which data frame we're looking at. And we use this method here to get a fit and then a summary. So with this summary, we can see what I'm really interested in is our R squared, which explains how much of the variance in the data is explained by our model. So we can see that about 6%, which is a pretty low R squared rate. Usually we want something that's a bit higher, like at least 50%. So unfortunately, this line does not particularly fit our data very well. There's a couple of other things here. One important thing to look at is the p-value, which is the probability that this t statistic falls within, oh gosh, forgive me for a second here. Our p-value basically defines how significant our model is. So, or how significant the relationship between our variables are. Sorry, excuse me. With these packages too, there's a couple of other things you can do, like residual analysis. We can look at the residuals here. We can plot them in a histogram, scatter plot, and analyze how those look as well. I can take a short pause here if anyone has any questions. I know that's a pretty quick overview of regression analysis. So please, if you have questions, let me know.
Just have a comment or two, just to
Sure.
mention that when people talk about sklearn, they often say scikit-learn, and it's famous for that. Just so.
Yeah.
And, the t-values for time series are often small, in my experience, in financial data, often very low, R-squareds, and we like to have a t that's at least over 2, but not always great. So that was good enough.
Yeah. Yeah. So when you're looking at, you want to look at everything as a whole, right? So yeah, our R-squared value is kind of low. So our model doesn't explain a whole lot, but we've got a significant relationship here, as we can see by the p-value. So another thing to look at would be, analyzing the residuals. When they're distributed, do they appear normal? In this case, it's a little bit skewed, but the general shape of it is pretty normal looking. The other thing we like to see is if you were to create a line at 0, there should be 50% of the residuals on either side of that line, which all of these, analyzing the residuals, we're looking for to make sure that our linear model, our relationship is in fact linear, is what I'm getting at. If we saw, for instance, like a cone shape here with the residuals, that would lead us to believe that our relationship may not be linear. So that's why, looking at the residuals is pretty important. Any other comments or questions? Again, I know that was a pretty fast overview, and if you need clarification, don't be shy.
There's nothing else in chat right now, Samantha.
Okay.
I guess if anyone else has questions, feel free to ask.
Yeah. So I'll switch over then to some more information on COVID data. I've got my presentation here. Let me just get this in present mode. So actually, hold on. Before I do this, I want to touch on one more thing. As I said earlier, I participated earlier in the semester in the Blueprint Datathon, which is hosted by Stanford. And I just have some information on Stanford's organization here. If you want to know more about the Datathon, there's some links here. Our project submission, there's a link here, which also has, the GitHub repo, as well as, our presentation link. And the question that we were focused on is basically disparities and inequities that exist in health infrastructures. So we were specifically interested in demographics and how that related to COVID mortality rates. So I'll go over to my presentation here. This is pretty long, so I'm not gonna spend too much on it. Feel free, if you go through it on your own and you have questions, I'll add my email in the chat later on, and feel free to reach out to me and ask me any questions you might have. But essentially, and unfortunately, I signed a non-disclosure agreement, so I can't provide you all with the data itself that we used, but there are our Python files in the GitHub repo if you want to take a look at the actual Python code that we used. So basically,
if you sign non-disclosure, I only want to ask, can you say where the data arose, where sourced?
yes. Let me stop my share for just a moment. I don't think we included that in our presentation, so I have to find it in my drive. Give me just
I don't want
second.
it to be a distraction. I just was curious.
Yes, I can speak. I just don't know the names off the top of my head. At the end, I can.
That's fine. I
Okay.
was just like, did you get it from Stanford? Or did you get it from the National Health Association? Or did you get, that's what I was curious
Yeah,
about.
it was a couple of organizations that Stanford worked with. I think it was 2 separate organizations that provided the data for us, and we got those through Stanford. And that was a required before we started we had to have these organizations, we had to sign these NDAs prior to participating. So yeah, I can give you the names of those organizations at the end. Let me go back here. Okay. So again, we were looking at health disparities. So we examined a lot of demographics, race, primary language spoken, income level, poverty level, age, and gender. And then we looked at a survey of reduced access to medical care across subgroups during the pandemic. And the factors we looked at there were gender, age, race, and education level. For this project, we primarily focused on regression analysis. We didn't really touch on, regression analysis, and we stuck with linear models. There was some data that did appear to have some non-linear relationships that we didn't particularly explore. So, those are some of our limitations. And then there's some inconsistencies in reporting. Some county, so, there's national data that we had, and then through this national data, each state had a certain number of counties that had reported, and some were quite inconsistent. California had 16 counties, Michigan 4, and New York's 9 counties reported. So it's a little bit of inconsistency there. This is just some general background information. These numbers are obviously inaccurate at this time, so I can't speak to them at the moment. But when we prepared this in October, the cases were at 8.5 million. That's 224,000. There was still some social distancing aspects in effect, and we took this data, and let's see here. I want to get into our results, really. So these scatter plots here are on primary language spoken and COVID mortality rate for some counties in New York. Or for all counties in New York. So our R-squared values are pretty high here. So our model explains, some of the variance between the variables. In particular, there's a negative relationship between only English speakers and mortality rate. So the higher proportion of English only speakers, the higher their mortality rate. No, lower mortality rate. I apologize. So, and there's a positive relationship between limited English and a language other than English spoken. So as the mortality rate for these populations increase, as the proportion of limited English speakers increases, so does the mortality rate of the mortality rate for these populations. Sorry, I'm getting my words mixed up here, and I apologize if it causes any confusion.
It's just a little unusual not unusual, but different, because the mortality is on the x-axis, and then you think of that as a predictor for the language, but that's actually not the way you're looking at it, right?
Right.
You're looking at it, yeah.
And we did struggle a little bit with that. So the other individuals on my team were undergraduate students, 2 of them in their first year of school. And so we did have some challenges. We're looking at, are these demographics predictors of mortality? So it took a little bit of time. There's a little bit of a learning curve to see and to explain, how we want to form this. This was.
Did you have any stories behind that? Is it because you think that they might not have heard the instructions because they didn't speak English, or did you go into any speculation on, because I think it's like kind of hearing this your thoughts on why it's doing it.
We speculate. I can't recall if we wrote anything in our conclusions, but we did speculate a little bit. Our thoughts are those that are non-English speakers or English isn't their native language may not realize the severity of their symptoms and might take might experience severe symptoms long term and not seek care for it. Or let's say, for instance, if a non-English speaker is an illegal alien, they may not seek care, and that might result in mortality as well. So those were some of our speculations. I think there's quite a few that exist. I think your mention of not knowing some of the recommendations, if they're not following CDC recommendations because they can't read it because they're not English speakers, I think that certainly would come into play as well. But specifically, we speculated on, not being able to access healthcare or not understanding the severity of their issue in order to seek healthcare.
Thanks for sharing that.
Yeah, for sure. So one thing I want to highlight on this page, and this is one of my team members, so it's not as fresh in my mind as some of the other work that we did. But the New York demographic data, residents who don't speak English do speak Spanish, Russian, Chinese, among other languages. Those are the 3 primary languages that were that we had in addition to, English speakers, which I think is interesting. Spanish, I think, is expected, but Russian was unexpected from my perspective, as far as, primary language spoken in New York. Let's see. So we also looked at the number of ICU beds available and cases per state, as well as people over the age of 60. So we took the county level data for each state and summed that in order to get some of these total case counts and the population proportion over 60. And then we graphed the total population with the total cases to find and to look at the relationship between them. And looking at these graphs here, let me just move this taskbar up so I can read. So the number of ICU beds and their proportion over 60, there does appear to be a positive relationship. So as number of ICU beds increase, there's a larger proportion of individuals over 60, which that makes sense to me. You know, if you have a county with a higher number of elderly individuals, I would think that hospitals in that area would have a larger capacity. Looking at the total cases, again, it appears that there's a positive relationship as cases increase. The proportion of those over 60 also increases. And of course, mortality rate, which is again expected as here we've graphed we've used age as a predictor of mortality rate again. So we're looking at, you know, can mortality rate predict the, you know, the proportion of those over 60.
Are each of those points a state? There are 50 points then, is that
Yes.
what that is?
Yes, that's correct. Yep, there are 50 points here, one for each state. This is a scatter plot of population group distribution by mortality rate. So the data that we had quite a few different, what's the word, groups. So those are all listed to the side, and it can be a little bit overwhelming to look at. They're organized by gender as well as age group. So there's less than 5, 5 to 9, 10 to 14, 15 to 19. And one thing that I didn't quite like about this is as the age increases, the groups are less consistent. So the lower ages are about 5 years apart. Once you get into like 45 to 54, there's you know, they start to the range of ages starts to increase. So that's, you know, something to consider as far as looking at there is a possible limitation to this particular data set because there's some variability between the age ranges. But you can see here that the highest proportion of individuals is those males and females aged 45 to 54. And it's interesting that their mortality rate is scattered quite a bit. There's some observations here. Like I said, people aged 45 to 54 at greater proportion of the population than those 16 above, so they ought to have a greater mortality rate. But we see that mortality rates for the two age groups are roughly the same. They follow this general trend of clustering around 20%, or sorry, around 2%, and then sparsing as the mortality rate increases. Let's see. This is the data that I worked on, race, unemployment, and health oh no, actually, sorry, not yet. This is another one of my teammates' work. They looked at, let's see here, the race and unemployment during the pandemic. So this time graph, unemployment rates skyrocket around March, which is expected. That was when the stay-at-home order was implemented. or, there's a national sort of recommendation to stay home. So the unemployment rate skyrockets around March, and notably Hispanics appear to have the highest unemployment rate at this time. And it stays pretty steady as the highest as time goes on, taking another spike here. Blacks as well appear to have another high unemployment rate, as well as Asians. Now, the Asian unemployment rate appears to be a bit more consistent as far as being a little bit higher, whereas whites, there's a sharp peak here. And then there's a quicker decrease of that rate as time goes on, which I think says a lot about some disparities that exist in the United States as far as those who lost their jobs during this pandemic. Let me see if there's anything else here. I really like this visualization. I think it really clearly shows some important relationships between demographics and unemployment rates as the pandemic went on. Let's see. So one thing to know is our team didn't have enough time or data to determine whether the two observations imply causality, but there's certainly a relationship between the unemployment rate and disproportionate mortality rate among Black and Hispanic populations, which I will go into just since we're talking about it. I'll come back to these visualizations. This is a survey that was collected about access to healthcare, which I will come back to. I want to talk about race population distributions in these 3 states. So this is in New York, where the green graph is the population of Asian based on the county. The orange graph, or the darker orange graph, is the population of Blacks in each of these counties, Hispanic and Latino individuals, and whites. What I found particularly interesting here is that there are certain neighborhoods or counties that have very high instances of these races. And then if you look at the proportion of white individuals, it's a little bit more evenly distributed. Moving on, race is a predictor of COVID-19 mortality. This is the national scatter plot of proportion population of Black individuals and mortality rate. So it's insignificant. What we found is the relationship was insignificant at the national level, but the variables are significant for New York counties. And there's a strong relationship between COVID mortality rate and the proportion of Black folks in New York counties. We looked at this a similar model for a couple of different races. One thing to note in particular is there's a positive relationship between mortality rate and Black individuals, and a negative relationship between mortality rate and white individuals in these New York counties. Again, there's a general negative trend as far as white and COVID mortality rate goes.
Are all those points counties that you had in your national plot?
Yes, so all of in the national plot, all of these points are counties across varying number of states. I think there was, I can't remember the total number of counties reporting, but there was at least 2 for every state, with some states having a large number reporting, like California, I think, had the most at 16. So varying levels of counties reporting, but at least 2 for each state. Go ahead, Charlie.
I was just wondering if the race clustering that you saw that was predominant in New York was partially related to the correlation you're seeing, and then there might not be as much clustering if you look at a national level. Just a thought.
Yeah, and one thing that I did know, I can't recall if I have it in this presentation, but one thing I found interesting that I wanted to explore further was the geographic location of these counties. Some of them, and I forget which ones, some of them are located around Manhattan. And then there are two, and I can't remember which ones, that are located near Buffalo. So thinking about that, does geographic location have something to do with mortality rate? You know, being at a hot spot like Manhattan, being near Manhattan was, of course, that's going to have a different proportion of mortality, a different mortality rate than those counties that are geographically further from, you know, a hot spot like that. So unfortunately, we didn't have any geographic information in the data sets that we had access to, but that is something to consider as well. Let's see here. I went through this. So I went through 3 different states, Michigan, New York, and California, and the results of our regression analysis for race were insignificant for counties in Michigan, as well as insignificant for counties in California. So I did not explore those states as in depth as I did as I did in New York. And overall, race has not proved to be a significant predictor of mortality rate, although the proportions for white and Black populations in New York counties was significant. Oh yeah, I did include some information on geographic location here. So the highest mortality rates were the Bronx, Kings, New York, and Queens counties in New York. These were all geographically centered around New York City. And the lower mortality rates were near Buffalo and Rochester, with the others being located near Long Island. So that's interesting to consider. Distributions of the race category show higher populations of white folks in New York counties, with Bronx and Monroe being the lowest. And then Bronx and Kings counties have high populations of Black, Hispanic, Latino, Native, Hawaiian, Pacific Islander, and other populations. Some compounding factors include geographic location, relationships between counties with high mortality rates, population density, county boundaries, and other counties in New York should all be considered in relation to the mortality rate in New York. Age groups and COVID mortality. This is where our linear regression did not work. This is particularly interesting plot of males and females aged 30 to 34. So you can see there's a slight curve here. There's the possibility of there being a parabolic relationship between these. I didn't even know where to go with this, to be perfectly honest. So I tried to do some multivariate regression here, with gender being an additional variable. It unfortunately didn't lead me anywhere, again, because of the nonlinearity of the probable nonlinearity of the relationship between these variables. I did mention at the top here, it would be beneficial to remodel these with a nonlinear regression. Unfortunately, I was unsuccessful. The regression analysis with male and female groups as interaction variables was significant. The correlation coefficient was negative 2.55. R squared was about 6%, and a significant p-value, actually. Even though they're significant, our model doesn't fit well. Perhaps quadratic.
Do you think that's really a significant variation? Because it only goes from 0.05. from the proportion of, is it that there's just, I mean, it looks like there's some sort of clustering, but if you look at how much of a variation in the y-axis, there's not a lot.
Yeah, it's difficult to say. I mean, I do think that because of the clustering, I do think that there is something. Okay, let me start over. To say it's significant is solely based off of, our p-value. That being said, I don't think that this is significant for a linear model, which, because the linear model does not fit the data very well, I think that the significance is, I don't know what the word for it would be, but I think that there's a high probability of that being an error. Like,
so
I think
the y-axis is the proportion of the population that's between 30 and 34.
Yes.
So it's saying that in some county, you have 4% of the population falls between 30 and 34. Right? That's what that's saying.
Mm-hmm.
Okay. And so that's the generally, and then, okay. So I'm just trying to understand what it's plotting. Thanks.
Yeah. And I apologize.
You don't have anything to apologize for. I'm trying to understand.
I wish I could say it in a clearer way.
Yeah, we all want to talk better, but you're talking fine for me.
So, there's some, I think that there's some interesting things to explore here that, unfortunately, with my current level, I'm not able to explore. So I think this in particular would benefit from some further analysis that's a little bit more specialized than what I was able to do. Some more challenges with nonlinear regression. I had attempted to fit a quadratic model to this data, but I was unsuccessful. Again, just with my learning curve. And the rest of our age data was, we had some difficulty again modeling it, just because it was the patterns were strange, and I think that has to do with the nature of COVID, affecting. Of course, it affects those in elderly populations a little bit more, but there has been some interesting effects of the younger populations as well. Before I finish up, I want to touch back on the reduced access to care. This was a survey that the CDC had produced, and it was analyzed specifically focused on the category reduced access to care. So these are individuals that felt that they were unable to get the care that they needed in general because of the pandemic. So for instance, if I was having stomach issues, I felt I had reduced access to my doctor because of the pandemic. So the values show percentages of adults who delayed getting medical care in the last 4 weeks, or who needed medical care at any time for something other than coronavirus, but didn't get it because of the pandemic. So we looked at these based on different groups. The one in the top left is based on race. So interestingly, multi-race individuals reported higher levels of reduced access to care, the lowest being Asian, reporting the lowest percentage of reduced access to care. Underneath that is education level. We have the national estimate in here, and then we've got less than a high school diploma and a GED below the national estimate, and then those with higher levels of education reported higher instances of reduced access to care, which I found that to be particularly interesting. The top right is age. So let's see here.
Is the general trend downward that care became more available for everybody later on?
Yes, the overall trend is these surveys were pushed at a regular interval over the course of the pandemic, and as time went on, the national estimate does have a downward trend. So as the pandemic went on, more people reported less instances of reduced access to care. The gender age is up there. I didn't find anything that really stuck out to me there personally. The gender I found interesting. It's females reported higher instances of reduced access to care over the course of the pandemic compared to males. So I thought that was interesting.
Is that anything that you'd think due to the amount that they're seeking care versus, because I mean, gender-wise, there have been anecdotal and other notions of men less likely to take care of themselves.
Yeah, you know, I speculate on that a little bit. My undergraduate background is in psychology, so I tend to speculate based on general behavior, and so I lean a little bit in that direction where men in general tend to seek medical access less than women do. So, you know, my thought is if a woman is on average, not including, you know, outside of the pandemic, is on average more likely to seek medical care versus a man, then I would think with the pandemic, they are going to report more denied care or reduced access to care because they're seeking it more often. So that's what I'm leaning towards, but I think that there could be a variety of different reasons. I would be interested to see some statistics on general health conditions and if gender is affected, or if some genders are more affected by other, you know, medical conditions more often than other, you know, male versus female, how like what's the relationship between different medical conditions and gender, and how that plays into this. So unfortunately, these don't fully represent the entire population accurately, but it does provide us with some insight in which groups could be experiencing reduced access to healthcare. There's an interesting observation here that around week 11, which was mid-July, week 11 and 12, almost all groups showed a drop in percentages. And, you know, one assumption is that states' requirements for citizens to wear masks could have caused this drop. But unfortunately, with the data that we had, we couldn't make that determination. We've got these are some closing thoughts that our team had with the Datathon experience itself. In general, I think that the pandemic itself has highlighted some very specific instances of disparities. And I think that it's important to look at this data, but also acknowledge that within it, there are quite a few limitations that most COVID data has. And that being said, at the same time, even though we have these limitations, I still think it's important to constantly, there should be some constant checking of this data, you know, review it, read the conclusions that are made from it, and then, you know, there should be some reevaluation processes that are, that occur as well, to make sure that, you know, we're getting, because it's still evolving, we're getting an entire picture. So even though this was done in October and we're 2 months or maybe a month and a half from that, and we've got an entirely new data set that needs to be worked with and handled, because things are changing. You know, we're in the middle, still in the middle of a pandemic, and things are changing quite rapidly. So that's all I've got for you guys. Are there any other questions, comments, insights?
I did have one question. So
Sure.
there was a lot of mortality rate data in there. And one thing I was curious is about the propensity of who gets tested and what kind of impact that may have had on the mortality rates. So for example, if people with less severe symptoms are not getting counted, then clearly you'd expect a higher mortality rate. And so I was curious as to whether there was information such as like positivity rates or something that you were able to help control for with that, or is that something that is just a limitation that still needs to be worked around?
Yeah, that's a fantastic question. We actually, if I recall correctly, we calculated the mortality rate based off of the proportion of total cases and the proportion of, the total cases and the total deaths for each county. So with that being said, we didn't have specific testing data. Like we did not have information on total number of tests or like negative tests versus positive tests. All we had was total number of confirmed cases, COVID-related deaths, and then we calculated, you know, rates based off of that. So that's, I guess, to answer your question, that's a inherent limitation. I think that's a really valuable point, though, to consider who is being tested, and how are there certain populations that have higher test rates than others, and how does that impact the mortality rates?
Thanks.
Yeah, for sure.
What did you think about Python as a tool, and how much had you used it prior to this study?
So to level with you, I actually did not use Python in this project. I focused on R just because I knew more data analysis. However, I've had another project where I've done some analysis in Python, and Python is so much easier. Just because I can work with the data in ways that I am not able to do so in R. So for instance, like I'm actually presenting on this project tomorrow if anyone's interested. It's on recycling contamination in the city of Lansing. And we sent out a survey and we got feedback from the residents, and then we used Qualtrics for this, and the output was very difficult to work with. So I had to I spent a lot of time cleaning and filtering the data in a way that I could work with it for analysis. And in order to read everything and get it cleaned, you know, in a way that I could work with, and then run my analysis, it was just 1,000 times easier to do that in Python than it was in R. I think I spent maybe 3 hours trying to figure out how to do it in R before I was like, you know, I can't do this, and switched over to Python and had it done pretty quickly. So that being said, moving forward, I will probably only use Python. Not to say that R isn't valuable, but I just think for the purposes of data manipulation, I think that Python is a lot more easier and it's a lot easier and it's got more functionality than R does. Does that answer your question?
Oh, yes, thank you. I thought that Python and R were going to be integrated in some way, or they have been, or I don't know if anybody has any information on that.
I can't speak to that. However, there are some packages. So the packages in my example, I can't remember what they're called off the top of my head. Let me see if I can find it real quick. But basically, some of the packages in my example use like R syntax to create models. And I don't know the full functionality of it. I only know like how to do like regression with these packages, maybe a little bit of bootstrapping. But these packages are designed to take our type input and spit out an R-styled summary. So the statsmodels.api and statsmodelsformula.api, these two packages are like the most similar to coding in R that I've used. But I don't know if there's any integration between the two languages themselves. Unfortunately, that would be great if that happens, I think. Just because R tends to be a little bit easier to do analysis in. But I think that the packages that are out there for Python, I think that you could just do the same thing in Python and it would end up being about the same as far as like level of difficulty.
Any other questions for Samantha?
I just wanted to have your thoughts on when you saw things disappearing at the national level versus some explanatory variables at the state level, to see if you're thinking that things might have moved different ways in different counties and it all averaged it out to a neutral, or what? I mean, if you have any thoughts on that, otherwise.
Yeah, I think it has to do with reporting, that there's a lot of states, especially I noticed that some of the southern states had fewer counties reporting than some of the other states. And I wonder if I had a box plot of, oh, these are mortality rates across states. Well, to answer your question, my thought is the number of counties reporting was inconsistent. And so I think that there's some drop off with that. But I don't know. I don't really have any other insights on what might have caused that.
I think the reporting is something I didn't even think about. That's a great, great observation. Yeah. Thanks.
Yeah, sure. Any other questions?
Any other questions?
Thank you, everyone, for listening to me talk for a long time.
Thanks so much, Samantha, for
Absolutely.
presenting on that.
Oh.
Yeah, I learned a lot about COVID data analysis, so that was good.
I'll share my email in the chat in case anyone has any other questions. I check out our GitHub repository if you'd like. If you've got any questions there, let me know, or any other insights, or if you just want to talk about things, I'm here.
Sure. No, thank you very much.
Yeah, absolutely. Thank you, guys.
Thank you, Samantha.